Thank you for joining us today for ESPERT, part of Project CARE, about integrated behavioral health care services in Kern County, California. We have 3 presenters today, and the first is Reilly Alvarez, who is the Kern County Behavioral Health System Administrator, or just retired from that position. She was the primary administrator responsible for the delivery of many of the publicly funded substance abuse primary prevention and treatment services. Also presenting today is Christopher Reilly, who is the Chief of Behavioral Health Services at Clinica Sierra Vista, the Central Valley's largest network of community health centers, and also Dr. Darren Urada, who is the Principal Investigator and co-investigator on multiple studies on the integration of substance use disorder services with primary care and mental health, and the effect of Affordable Care Act IBSYD services. So these are our presenters today. Now, before I turn it over to them, we have a couple poll questions that we ask at the beginning of each webinar, and this is just to get an idea of the participants today and what fields you represent. So if you will please look at the question that's showing on your screen now. It is, what field do you represent? Are you a counselor, a therapist, social worker? Are you a nurse or nurse practitioner or physician or physician assistant? Are you a program or unit administrator, university student or faculty, or other? Okay, just a moment, please. Okay, thank you. I will now close this poll and we'll share the results. Okay, on the program, just a moment, please. Okay, on the program today, we have in the audience 15% are counselors, therapists, or social workers, or caseworkers. We don't have anybody from the nursing or physician services today. 38% are program or unit administrators, 23% university student or faculty, and 23% other. And in the other, please indicate in the chat or questions box what that field is so we will have it for our records. One of the problems with these polls is that I only have 5 options for answers, and it would be nice to have more so that we could get that information out there. Okay, now we will go on to the next one. And this is sort of tied to the first, but it will it asks a slightly different way of presenting the question. What field do you represent? Are you in mental health? Are you in addictions, physical health, education, or EAP? Okay, I think that's a good representation of the audience, so I will share the results of that. The viewers today have 38% from mental health, 50% from addictions, nobody in the physical health care field, 13% from education. Thank you. And now these are going to be really quick yes, no. Oops. Okay, sorry. Let's go to the next one. Okay, do you conduct ESPERT interventions? Yes or no? Okay, thank you. I will close this and launch and share the results. 50% yes to expert interventions, and 50% said no. That's really interesting. It's the first time that's come up. Okay, and then here's the last one for my polls. We have a couple others throughout the session too. Do you see your agency using expert? Do you currently use expert, or is your agency planning on using it? Okay, thank you. This is the result of the last poll in this session. Of the people in the webinar today, 89% of their agencies do currently use expert or will be using it in the future, and 11% say no. So thank you all very much for participating. Again, the presenters have a couple polls later on, and we'll be doing those. So please be on the lookout for them and participate in those as well. We appreciate your participation. So I'm now going to turn the screen over to Christopher Reilly and Lily Alvarez for their part of the presentation. Oh, hold on just a moment, Chris. I have to unmute you. Okay, there you go.
Good morning. This is Lily Alvarez. I'm going to start out. I'm going to probably talk about maybe 15 minutes. The bulk of our presentation really is what's going on in the clinics, and then we'll end up with our evaluation. Let me start out by telling you a little bit about California. We have a very unique opportunity in the state of California in probably about 2005 with a ballot initiative that would impose a 1% tax on millionaires in California. The act was known as the Mental Health Services Act, and that did pass, and so there is a stream of dollars that are coming through the tax base here in California that are intended to transform the publicly funded mental health system. And as part of that transformation, for the first time in probably about 40 years, there were dollars that were going to be dedicated for prevention and early intervention work. Our county wanted to use these dollars, a portion of these dollars, to initiate work with primary care clinics in anticipation of the Affordable Care Act. And so what we did was that we built, if you will, a project where we would go into partnership with FQHCs. We also funded one of our county hospital outpatient clinics. And as I said, the entire focus of our project was to see whether or not we could build capacity. What I mean by that was, could we deliver mental health services for mild and moderate disorders, and could we build services for addiction disorders in primary care? Let me back up and just say that Kern County Mental Health is the carve-out or the specialty provider in our county, and so this was giving us an opportunity to work with those individuals who might not necessarily meet medical necessity criteria for specialty mental health. So what we did was that we spent probably about a year in 2010-11 planning for integration. And what we knew we wanted in this project was to have universal screening. We wanted everyone to be screened. We selected, if you will, very specific screening instruments that are actually available in the public domain. We selected the PH29, the GAD7, and the Audit C for our screening tools. We also wanted to have warm handoffs, and so what did that mean? That meant that we wanted to be available in the exam room and have live bodies, if you will, that the physician or the mid-level practitioner could hand off a client to, or a patient to. We wanted to see interventions. We wanted to give the clinicians the ability to deliver whatever kind of interventions, brief interventions. We also required something that we ended up calling huddles, but they really were about team building. And what we required in our contract was that the physician in the clinic had to be the team leader. And so these huddles were, we didn't say that they had to be 15 minutes, a half an hour. We didn't say they had to be once a week, every other day, daily. And we didn't say that you had to keep notes of these huddles or anything like that. So what we were doing was trying to impose, if you will, what we think the literature was saying was that you would meet, if you will, integration if people came together and talked. Psychiatry consultations were part of our project, and we did not, while we supported interventions, we did not limit that they would deliver treatment. And as we go through our project, I notice many of you are coming from the substance use disorder field. I was very interested in wanting to see whether or not we could use certified substance abuse treatment providers to be effective in primary care. So therefore, we put no barriers on who would be allowable providers. Many of you probably are very familiar with what I term as the Holy Trinity for Medicare, which is the physician, the clinical psychologist, and the licensed clinical social worker. But there are many other behavioral health providers. Certainly the certified substance abuse provider, that clinician, we suspected we were going to see SUD in these clinics, and so we wanted to make sure that these clinics knew that they could hire those kinds of providers and it would be allowable in our funding. We also didn't require that the psychiatrist had to have a face-to-face encounter with the client, but rather could, if you will, sit in case consultation or with health registries or sit with the physician and give consultation. And we didn't say the psychiatrist had to see the patient. Another feature is that we put no limits on how many services the clinic could provide in the same day. Remember that these are tax dollars, these are MHSA dollars here in the state of California, and so there there weren't rules for us that required that we could only provide one service in the same day. And so obviously we had a lot of freedom to be able to experiment. We're not done. I think that there are still issues related to when are we, what's the boundary line? When do we refer to specialty carve-outs, and when is it appropriate to deliver the services in primary care? We also know that there's information that needs to be exchanged. I know that certainly in the FUD field, we have a lot of issues related to confidentiality. But it's my belief that there is information that can be exchanged even within the context of 42 CFR, and we need to be precise about that information. The other thing that I found very exciting about the project was something called a health registry. And given the population sizes that health clinics serve, we're talking about thousands of people, not tens and 20s, that typically come into substance abuse treatment facilities. There's a question right now. Thank you. Somebody answered it. What's an FQHC, federally qualified health centers? Let me just say that there are only 2 entities here in our county, Clinica Sierra Vista and Omni Health. Both of those clinics responded to our request for proposal, and so we selected both of them. Between the 2 of them, they probably represent about 34 clinics in our county. We selected 4 from each one of those FQHCs in addition to our county hospital outpatient clinic. So for the last 3 years, we've been working with 9 clinics, and that's what you're going to hear about today. I'm going to turn it over to Chris Reilly.
Okay, thank you. Let me start by saying 3 years ago when we started this, the landscape looked quite a bit different than it looks today. And yet even today there are so many unanswered questions. We are abiding by one model that I'll describe, but I'm excited to hear other people's models throughout various conferences and meetings and opportunities to interact. And it varies quite a bit by state and by funding source and by what you have in place. So today you hear about primary care medical homes, and Clinica Sierra Vista is a joint commission primary care medical home. You'll hear about affordable care or accountable care organizations, but we're still funded, at least at Clinica Sierra Vista, on a PPS rate, a fee-for-service model that pays you, in effect, to per widget, right? And the widgets we've been making for the last 43 years are services to mommies and babies. When you think about the first challenge of saying we'd like to bring integrated behavioral health into the health center, what the providers like to see when they walked into work in the morning was a room full of mommies and babies, and the staff like to see a room full of mommies and babies, and the mommies and babies like to see a room full of mommies and babies. And if a behavioral health patient wandered into the room, people would sometimes panic and go, where's mental health? We get this person to mental health, and we need more help for mental health. And my mistake early on was thinking when they said we need more help with mental health, what they wanted was a mental health provider in the health center to help them. What I was first confronted by was what they wanted was the mental health or substance use patient to leave the health center because it was a threat to that mommy and baby culture that we had. So you look at the way specialty, and even today, mild moderate is defined, and you have the primary care provider saying this person's too complicated or too severe for me to see, they should go to the mental health plan. And the mental health plan says, yeah, they may have a bipolar disorder or something, but it's stable, they should go back to primary care. And so there's this push, there's this toss back and forth between where a patient should go. Enter the Affordable Care Act, and now you have another entity involved in this definition, and that's the managed care plan. Your Medicaid, or in California we call it Medi-Cal, but your Medicaid managed care plan in some counties says, well, if the person could qualify for specialty mental health, then we don't want to pay the claim for them if they're delivered the service in a primary care setting. We only want to pay for mild, moderate. And similarly, then you have the medical necessity for specialty plans. So what we still need to work out today is who's supposed to be seen in the primary care setting, and who's supposed to be seen in the specialty setting, and by what means are we defining that? Our challenge in the beginning was to try to loosen the door on the primary care side and point out that we could do a lot more through substance use screening, through brief intervention, through the support of behavioral health providers in the community health center setting. Something to consider for those of you not as familiar with an FQHC. FQHC is basically a safety net primary care provider, and we operate on ultra-thin margins. If you're in California, you have, I think, the second lowest Medicaid reimbursement rate in the country. And you're paid for one visit per day per patient. So if I can take a minute just to break this down a little for this audience. The ideal patient has one problem, is seen in 15 minutes, and is satisfied with the result or the resolution of that problem. Again, why mommies and babies are so desirable, because the child has a sore throat, or the child has a earache or something. And it's easy to solve that one problem. Behavioral health patients often come with many more complicated problems. They've been homeless, they have diabetes, they've got swollen feet, they've got a hernia that's falling out of their gut and it hasn't been treated. They have a myriad of health and mental health problems, and very often aren't articulate about those problems. So it creates stress and anxiety on the primary care system that needs to get through 24 to 30 patients a day, when the behavioral health patient walks in and has a hard time explaining one, say nothing for the 4 or 5 other problems you need to treat. So it slows that widget making down. So we start by saying, okay, well, good news, at these 4 of our 18 community health centers, we're going to bring a behavioral health provider in to help you, to consult with you. And the first trick is, okay, is that a psychiatrist you're bringing in? Is that somebody who can fill the meds for this person? In our model, it was a psychotherapist. And the sort of, this is kind of a cliche at this point, but the therapist walking into this project is used to a 45-minute therapy session with a sign on the door that says, don't bother me, with a room that looks nicer than an exam room, decorated and dimmed, and that room may have to have a multi-purpose at some point, but even if we get a dedicated room for you, having a patient sit in a session for 45 minutes while the therapist is unavailable runs counter to the warm handoff and immediate consultation need of the primary care provider, or the 2 or 3 of them who are seeing 4 patients each in that same hour that you're trying to see the one. Therapists tend to be a little more talkative and want to process through things. If they have a tough session, they want to go talk to another therapist and tell them about the tough session and what did you think Mary's issues were and so on. In our model, we had one behavioral health provider, one therapist at each health center. So the person that the therapist would seek out to process or debrief with would be the provider, who had 4 more patients to get to. And a provider might give you 5 minutes in the hallway and really feel like he took a lot of time to help you out and be part of the team, and the therapist would walk away from that same 5-minute visit and feel like they weren't liked or they weren't important or they weren't respected or this kind of thing. So we had to look at ways to merge the 2 systems. And these are some of the lessons we learned. So initially, in our first effort, we had brought mental health plan or county workers to the community health center. And what we found was that having somebody else's team come in only some of the time, placed in the other end of the building, and on their own schedule with their own supervisors caused the two systems to segregate further, and you basically had underutilized behavioral health providers. Our primary care providers didn't feel terribly comfortable calling on the mental health plan's therapist. The mental health plan's therapist didn't quite know how to break in and get attention in time from the primary care provider, and we really saw almost nobody. One of the things that therapists tell me today they like a lot about the work in the community health center is the blind or cold exams and evaluations. Typically in our behavioral health center, when you meet a patient, you do a full biopsychosocial assessment. You have their treatment records from their previous providers. You have access to their most recent crisis visit and so on. When you're in a community health center, the patient had no intent of seeing a behavioral health provider when they walked in. Under our model, we've universally screened the population, so all the patients get a screening. PHQ-9 for depression, a GAD-7 for anxiety, and an Audit C for alcohol. And then the primary care provider looks for threshold scores and may make a referral to the behavioral health provider based on the threshold score or just based on the interview. Having the survey invites the provider to bring up the topic with the patient, who often gives a different answer than they just gave 10 minutes ago in the lobby filling out the screen. But either way, I came in for a tummy ache as a patient, and now somehow I'm talking to a behavioral health provider, and why am I doing that, and who are you? So for the provider to be able to engage patients immediately from an exam room in a warm handoff and explain what we were doing took practice, and it took courage, and it took looking at the mental health service in a different way. You're coaxing people into some kind of care and treatment. And that's where the motivational interviewing and the expert are such wonderful tools in a primary care setting, because you really are now offering the client an invitation to think of something a little bit different. Large numbers of patients waiting long periods of time in bustling, crowded waiting rooms. I talked before about how as you bring behavioral health patients into the community health center, the wait, which is the #1 complaint we face from clients, becomes even harder to manage because you have multiple concerns and issues with each patient you see. And finally, we had one psychologist who said, well, I don't want to go into the health center. That's where all the germs are. So what we knew of integrated behavioral health models always depended upon some kind of third-party funding, included in this case the MHSA funding through the county of Kern to help us pay for providers that aren't part of the trilogy that Reilly talked about. They aren't psychologist, social worker, or physician. But we wanted to set up a model that could sustain itself just in the community health center encounters model that we already use. And what the MHSA and the relationship with the county gave us was the time and the support to develop this. The other nice thing that we had going in is we already had specialty mental health subcontracts with the county mental health plan, so that we had 3,000 patients in specialty already, and we had a place where if we met somebody in mild, moderate, and they were too complicated or difficult for us to manage, we could move them up into specialty, and we similarly had a place to step people down from, so that there was always capacity in the specialty behavioral health centers to continue to serve the patient population. But our model was constructed to work as if there was no mental health plan support and no MHSA, and LCSW psychologists and or psychiatrists only, no same-day visits, services contained within the 4 walls of the health center, and something that we could replicate across the 29 community health center sites that we run in Kern and Fresno. So we brought in our own providers. Rather than have people in Tuesdays and Thursdays for mental health day, or trying to take 4 providers and rotate them through a dozen centers, what we learned from that first experiment was if we aren't there when the primary care providers needed us, they would very quickly forget us or find us undependable, like a slot machine that didn't hit enough, they would quit calling. And because we were bringing people into health centers that were already built at this time without behavioral health in mind. Our provider office was the far other end of the building than the nurses' station and the exam rooms where the physicians hung out. So we needed to be able to be there 40 to 50 hours a week full-time. When the health center was open, the behavioral health provider was there. So in our model, we assigned one full-time behavioral health provider at each community health center. And the next trick is that they are part of the community health center team. They aren't a specialist coming in like a podiatrist comes in a day a week or an OBGYN. These people are full members of the community health center team, whether the community health center liked it at first or not. And they ended up loving it. That's the good news. They can't live without us now. But initially there was quite a bit of resistance. So that means that our behavioral health provider abides by the office manager, comes to all the health center meetings, keeps patient records in the community health center records, follows the meal breaks, understands the Joint Commission standards for ambulatory care, as well as knowing the behavioral health care. And we really didn't know we really didn't know how the assimilation was going to work. So what we said to each provider was make the primary care providers happy. And if I could amend that today, I would say make the community health center staff happy, the registration clerks at the front desk, the MAs, and make the primary care providers reasonably happy. They can be a little tougher. And stay busy. You're looking at people who see 30 patients a day, and it's going to take a while for them to appreciate or understand why you might see 10. And if you weren't in the community health center, you'd be in a behavioral health center, maybe seeing 5. So anyhow, Darren will show you some slides later on that tells you the difference in the perception of how we felt we were received by the providers and how they felt having us there. But for a group of therapists, PCPs were hard to receive. So we send them in, we say, make the providers happy, stay busy, learn the rules of the health center, follow the rules of the health center, fit in with the health center, and still, a month or 2 into it, we're getting no referral, very few referrals, right? 5 a week, 6 a week. We had heard before we went in there the horror stories about how patients were coming in and peeing in the plants, and they were raising a ruckus, and they were fighting outside the door, and where was mental health? But when we got in there, those were stories about things that happened once every 6 months that everyone kept telling. They weren't the usual kind of patient that anybody was identifying. So I guess let me back up for a minute and say one of the things we were learning was while we imagined the community health center was all mommies and babies, there actually were quite a number of people in the community health center who had substance use, mental health, domestic violence, pain management, and other issues that were quite appropriate for a behavioral health provider to help. And we knew statistically, we read research that said 1 in 4 people has a mental illness at any time, and we were only looking for mild and moderate. So what was going on? That's a line from, I can't remember the name of the movie now, but it tells you how old I am. There was I See Dead People was something that one of the patients wrote on the PHQ-9 screening that we passed out in one of the health centers. And he came up to the registration clerk with his survey, and she saw that, didn't know what to do with that, started to panic. He was kidding around. We had another incident where in I won't tell you the name of the clinic, but in one of our health centers, after getting lots of screenings back, we suddenly got no screenings back for about 2 weeks. We went up there to ask the front desk, what's happening with the screenings, what's going on? And the front desk said, I'm not passing those out anymore. I gave that to a patient. He came up, wanted to know what it was my business, started yelling at me, threw the thing at me, wanted to know why I was asking him these questions. So our first effort to try to get more patients and to better utilize the availability of a behavioral health provider in the primary care setting resulted in underutilization. So we tried to push these screenings some more and had to contend with people who basically didn't want to fill out the screening or faked bad or faked good or whatever. So we were handling crises, but we were not handling much else. On this slide is a quote from a doctor at great guy who today would give you an entirely different quote. But at the time, I said, would you mind just asking in the course of your regular visit, maybe, patients once a year or so, about alcohol and about how the home life's going, how their kids are doing, how their spouse is doing. We're here to help. We don't want to sit here and do nothing. And his answer was, they don't want to tell me and I don't want to ask. People do not come here to be harassed by their doctor. They come here for their sore throat. I want to take care of their sore throat. It's an affront to ask patients about their substance use. No, was his answer. So on the upside, the days of calling the police, which would happen not terribly often, but they would happen, had died. At the 4 health centers where we had behavioral health providers, our behavioral health providers were the police, and that's when we would be called. What made the difference was getting the right providers into these settings. People who had I don't want to say it exactly, a salesman's mindset about rejection, but there were people who did not mind the cold shoulder, didn't mind being uncomfortable, would spend their time hanging out at the nurse's station. So if we had 6 exam rooms surrounding the nurse's station, they'd say, hey, did we get a screening from the patient in exam room 3? Oh, well, I can take care of that for you. Let me go in there and do that. Folks who would be visible and present and humble and disciplined, right? So I have a couple tips up here on just if you haven't started this yet. These are my suggestions for the kind of person who makes the good pioneer, bringing behavioral health into a community health center setting. If you look at that 3rd bullet, seeing patients without any knowledge of their prior mental health history, knowing that when you meet this patient, as little as you're going to know and as cold as that read is going to be, somebody who's confident to say, I can patiently walk through a motivational interview with this patient, an expert interview with this patient, a depression screening, and I know at the end I will have some better idea how to treat this patient, even if I'm not given much to go on when I start. So one of the things that we would see on the initial referral firms was the quote you see there, room 3 crime. That might be all we get, and we got to, help having, and we got a lot of help from our chief medical officer and from the providers there, helping them understand what we'd like to know to put on the referral, so we have a little better idea how to engage with clients. But being okay with not knowing quite what to do is the necessary characteristic to have when you go in there as a provider. So that's a blind pig stumbling upon an acorn. That could be Chris Reilly, my blind pig stumbling upon an acorn. We thought when we started, from what we had heard and seen from other integration efforts at the time, that we would have somebody that did a lot of care management from a behavioral health perspective, that might be somebody who helped link you to the county mental health system, got you over to a substance abuse provider, gave you a little bit of psychoeducation about what might be contributing to your depression, and the need to sleep well, and how to take your meds. But what we found was we couldn't find LCSWs to go in there. We couldn't find enough LCSWs to see as many patients as it took in our model to make up for the number of people who did not have Medi-Cal. And remember, we wanted to create a volume that would allow this to sustain itself. So if only 1 in 2 people had Medi-Cal, that meant you had to see 2 people to get 1 payment. So it's a busy schedule. Plus, we were trying to keep up with the provider need anyway. So we therefore had to use ASWs, which are the MSWs who are gathering hours before they sit for their exam to become LCSWs, and MFT interns. And thankfully, with the grant from the county, we were able to do that. And I would add in there substance use counselors also later on in the mix. But to start with, we're looking at ASWs and MFT interns, and then later the substance use counselors. And those people have to accumulate hours of face-to-face psychotherapy in order to be able to sit for their exams and get licensed. And they have no interest in doing 15-minute psychoeducation, care management referrals, because that's not getting them the hours they need to become licensed people. So we, for this is the blind pig part, the wonderful thing was we had to make this a psychotherapy service in the health center. And how are we going to make it a psychotherapy service when we had a model that was supposed to be built on many encounters in a day and all access to the primary care provider. So I'm not sure where I can't remember which screen, which slide talks about, so I'll talk about it now. We found one of our providers came up with a pretty cool system. She managed to set aside 30 minutes of each hour for ongoing psychotherapy for returning patients, and the other 30 minutes of each hour was to accept warm handoffs and provide consultation with the primary care providers. As time goes on, as we're pushing, as we're at the nurses' station, as we're getting to know people better, we're getting those referrals that we weren't getting in the building. So to be available so we could take these warm handoffs, a 30-minute session meant that for most patients, they weren't waiting more than 15 minutes to be able to see the behavioral health provider. And given that you might wait an hour or two in a busy health center to even get in to see the primary care provider, this was proving to be a short enough wait that we were catching people for a lot of warm handoffs. Last quarter, just to kind of bring you up to speed, we had 1,150 patients seen, but they were seen for about 4,000 encounters, meaning most patients were seen once, and a small percent were seen for regular ongoing psychotherapy. So you could have 50 people in a health center who are being seen for regular psychotherapy once a week, once every 2 weeks, and they're coming in that 1/2 hour. The other half hour is being used then to do those single visits that are so often the more common visit we do, and are what are actually the solicitation or the invitation, the opening to become an ongoing patient. So some behavioral health concerns are made for primary care integration. A lot of domestic violence we end up seeing, much more than we thought, which of course has all the drug and alcohol comorbid conditions and complications that you'd expect in domestic violence. So having staff who are trained in substance use disorders and counseling, our MFT in one site is also KDAC, which is a California Addiction Counseling Specialist. The wonderful, discreet way of walking into a health center while the spouse who beats you waits in the car thinking you're there for the doctor, and being able to sneak in the therapy, phenomenal. Another nice surprise that came from this. The other nice thing is we're in all these, Kern County is this sparsely populated, large geographic area. And being able to be in the health center means you don't have to travel 15 miles on a 2-lane road with whatever gas is in the car to the behavioral health center that says behavioral health on the outside. It might as well say Clinica Loca on the outside, right? Local. But you can get your care right there down the street where you get your other care. And then what we tried to do in presenting the model to the general population was talk about the holistic value and relationship between mind and body. And some of these things people have heard enough that it resonates with them to say this particular health center is interested in your whole well-being, including your mind and body and so on. And so really turned out to be a welcomed, much utilized program for things like pain management, domestic violence, in addition to the anxiety, depression, and substance use that we expected to fund. So our next part was, how are we going to make this work when the grant ends and we don't have the funding, we have to pay for it ourselves? You can see here my simple math. That's a little high, but maybe not. A licensed clinical social worker plus the cost for their benefits and the overhead cost is about $105,000 per year. Assuming that you have PTO stands for paid time off, vacation, sick, holidays, right? Assuming that person works 1,840 hours a year, and assuming that you're getting a $100 encounter fee for service, and finally then looking at a 45% Medi-Cal patient ratio, which was our Medi-Cal patient ratio across the 28 health centers, you can see the math requires that 4.6 paid encounters occur a day. So I'll take a break here for a minute and kind of bring everybody up to date. How you get paid is changing. Depending on where you're located, some folks have been able to get the local Medicaid managed care plan to give them a capitated rate that lets them hire peer specialists and substance use counselors and all kinds of other than LCSW psychologists, psychiatrists, because they're paid per member and they're paid to basically keep people well and keep people out of the hospitals and keep people out of the health centers, and there's all kinds of incentives. And that's wonderful, I think. I think if you can get the right capitated rate, that gives you a lot of freedom to do more than our single behavioral health provider mixing in with the primary care team. But you have other counties and plans where the even with the Affordable Care Act's coverage of mild, moderate mental health, you have to get prior authorization, or the plan doesn't pay for severe if they think the client really wasn't mild, moderate. And so you really need to understand how you get paid. We have not had any problem getting paid by our plans for the severity of the client. We can see nobody's asking us to prove that the schizophrenic client couldn't have gone to the county. But one of the plans is making us get prior authorization. Well, I said earlier, 1,150 patients seen about 4,000 to 5,000 times a quarter means a whole lot of people are only seeing us once, and those will become unpaid encounters. So this requires some work individualized at each end to try to make this pencil out for you. Universally screening all the community health center patient clients just increased the chances that we'd be able to capture and identify and invite those from that population that could come in. I showed you only about 1 in 9 patients return for ongoing sessions. In order, because the Medi-Cal or Medicaid ratio was only about 45%, we had to have 10 recurring psychotherapy appointments a day because we weren't getting paid for half of them. Now, in January, when California accepted the extended Medicaid provision, and now you didn't have to be a mommy and baby or mommy or a baby or disabled to get Medicaid. You could be poor. You're 18 to 60-year-old adult. We've seen that number grow from 45% to almost 70% in the health center. But here's the catch. Only 56% of those with behavioral health encounters have the new expanded Medicaid. So still a challenge even 6 months into the new benefit to get people enrolled in Medicaid. And considering, again, the patient who comes in with swollen feet, diabetes, depression, drinking, hasn't seen a doctor in a long time, maybe has head lice, and is already having trouble communicating all that. Adding to that, I need you to complete the Medi-Cal enrollment is one more challenge, but it may be the most important challenge. We have Medicaid enrollment people there to help you at every health center, and we got to get you signed up. Many people have said to us, hundreds of people have said to us things like, is this Obamacare? Is this that socialized medicine? I don't want that effing socialized medicine. And now you're really stuck. Now you got somebody who's now it's going to take a little bit longer to get them that Medi-Cal, so we can reduce the, so we can spend more time with patients because we don't have to see twice as many to get paid. Therapy modality and approach must match the demand for service. So if you're only going to see most people once, and you're going to see some smaller number, 1 in 9, 6 to 10 times, it really helps to have a brief therapy model in the community health center. 30-minute sessions I talked about, and I think we talked about that part too. What's on here? Let's see. We did end up having a nice negotiation through the huddle process, in which the primary care providers were far more agreeable once we were in the health center to provide the medication management for our behavioral health patients, initially just knowing that they could talk to the ASW, the social worker, about what do you think's going on here? Well, I think Mary's drinking and she's dependent upon Valium because her kids are running in a gang and her husband's beating her, and okay, and that helped them inform and feel better about how they were medicating people. And what we thought was the provider didn't distinguish the discipline as well as we wanted. We really didn't want social workers and MFT interns not directly, but even indirectly determining the kind of medication management that went on. So we proposed that we'd have a psychiatrist do the initial setup. The psychiatrist would do the first line of meds, and if the psychiatrist gave you a nice psychiatric evaluation on that first line of meds, would you as the primary care provider be willing to manage those medications? And the gentleman's agreement we came up with was, we'll do that first line of medication if you need it. We'd appreciate it if you would struggle a little bit or try a little bit on your own so you had a specific question. I'm giving a lot of Xanax, but the patient keeps telling me it's not working and they need more. It's above the threshold. Can a doctor look at this, please? You know, so we knew what we were answering. And then in exchange, the primary care provider would continue to do the med checks for the patient. If there was ever any concern by the primary care provider that too much time had gone by, the patient wasn't responding, they didn't understand the purpose of the meds, whatever it happened to be, they could always go back to the psychiatrist and get a reevaluation done. And this saved a lot of the capacity in our behavioral health centers for the more severe and less stable patient, and let the severe and stable patient be seen in primary care. I'll leave the plan. The plan's been wonderful. I have nothing. The last bullet is outreach to the mental health plan. That, again, is your county specialty mental health people. I've loved the plan, and one of the struggles the plan faces is everybody until January has known if it's mental health, you go to the county. If it's mental health, you go to the specialty provider. There's nothing but the specialty provider. So it takes a long time to break people of that habit, and the specialty provider is inundated with referrals for folks who don't meet the medical necessity for specialty. What we simply did was call out to one of their central points of access and say, hey, when you have clients that don't meet your criteria, would you please let them know about or call us and link them to one of our, what are called the project care sites, or one of our integrated behavioral health sites. A model of practice, by the way, that has worked phenomenally well for the other FQHC involved in this plan and then we further defined what the threshold scores were, so that if you had a provider who saw a lot of depression on a PHQ-9 but didn't really want to get into it, didn't know how to read it, they could simply say a 10 on the PHQ-9, a 10 on the GAD-7, a 5 on the Audit C. Those are threshold scores. Go ahead and make the referral to the behavioral health provider. About half of our referrals come from those screening tools, but about half come from the provider simply having a reason to start a conversation with you, feeling uneasy about you, and then referring you over. I think I'm going over my time. Sorry. Am I okay? All right. So there you go. So 4 behavioral health providers in 4 rural community health centers are averaging 182 encounters a month, or about 8.3 per day, just shy of the 10 that we need, although today, now that we have 56% and not 45% with Medicaid, 8.3 is fine. Here's the last sort of hurdle we face. We need LCSWs. We need people who can get paid. This is a little bit old, so let me explain. In California, the State Department of Health that manages Medicaid has said, well, we know there aren't enough LCSWs or psychologists or psychiatrists, but that's who CMS and the feds will cover. We're going to let the health plans contract with you for MFTs, LPCs, I think many people in other states have LPCs, and ASWs for whatever rate they want to contract with you for. But the problem for a federally qualified health center is the state will not allow us to include the costs of the MFT, LPC. This is getting too in the weeds. But suffice it to say, we haven't quite worked out how to get more than just LCSW psychologists and psychiatrists into the health center. But we're getting closer and closer all the time. So in the meantime, grants, MHSA money, agreements with the mental health plan, fundraising, bicycle-thon things help us supplement the LCSW shortage with others. But as I mentioned earlier, if you can work out in your particular settings pilot projects, test projects with your managed care Medicaid plans that would pay you somehow for the use of a broader range of therapists, you have that many more people and that much more ability to get to clients. That was my fly in the ointment. We need and enjoy the support of behavioral health providers. Oops, sorry. So this is going to be over to Darren. Let me just look quickly at the question list. Are there any more questions?
I didn't see him.
Okay. All right. So I will now pass this over to Darren.
Hello.
Or to Christine to pass to Darren, maybe.
Yeah, hi, this is Chris. I will now transfer the screen to Dr. Urada. Thanks so much for your presentation. Just a moment. Okay, Dr. Urada, there, I unmuted you now, and we can see your screen. Just go up to slideshow. There we go. Thank you so much.
Okay, thank you. Can everybody hear me?
Yes, thanks.
Okay. So thank you, Chris and Lily. One of the things that we were brought in as UCLA to evaluate is what exactly is going on with the integration and the perceptions, as Chris said, the perceptions of doctors and behavioral health workers of each other and of an integration are a critical part of this. If they're bought in, then that makes things work a lot easier. And I see my slides are not. Let's see. My slides are not advancing. Oh, maybe I did this wrong. Ah, there we go. Or not. Okay. So we did surveys of the primary care providers and behavioral health providers. We also did the other general staff, but I'm not showing that right here just to keep things simple. And we wanted to know how much did they perceive these efforts as being valuable. So we asked primary, behavioral health providers, how valuable do you think your services are? How valuable do you think the primary care providers value your services? And they thought on a scale of 1 to 5, yeah, they value us. It was about a 4. And then we asked the primary care providers the same question, how much, but worded so how much do you value the services provided by behavioral health providers? And it was actually, I value these things, and they agreed even more strongly. So that's a significant difference between the two. So the interesting thing here is, if you are a behavioral health provider, and I know we didn't have any primary care people on here, so we'll talk about them for a little bit. The primary care people actually value your services more than you think they do. So that's sort of good news, bad news, but I think it's mostly good news. So we did this again the following year after sharing these results back with the Project Care participants, and we found much the same pattern. It did close up a little bit, perhaps because we had gotten the word out that yes, primary care people really do value your services, or maybe they had gotten better at communicating. So we also asked about communication. Oh no, I'm sorry, wrong slide. We asked how much do primary care providers value specifically the screening information that they were doing, that Chris talked about, PHQ-9, GAD-7, out C+. And behavioral health providers, once again, the same pattern, said we think they sort of value it, but it wasn't really very high on this 1 to 5 scale. Primary care respondents actually reported valuing it even more once again. So we asked, okay, well, what about communication? How's the communication between behavioral health providers and primary care? The question was actually, communication between medical and behavioral health staff is good. So behavioral health providers sort of agreed with that. It was a 3-point-something on a 1 to 5 scale. And when we asked primary care providers, they said communication is great. So I don't know if this is some sort of a cultural thing or what, or perhaps information flows mostly from the behavioral health providers to primary care providers and not in the other direction so much. But primary care thought communication was great. Behavioral health, not so convinced. The following year, a year later, we asked the same thing, and it did improve among behavioral health providers, which is good. It also improved among primary care providers. So that gap remained, but it did I think all these efforts with the huddles and meetings, it did go up overall. So we had another question that asked, do you recommend that other primary care providers integrate behavioral health into their facilities? So not where you are, but would you recommend this to others? The behavioral health providers were almost unanimously in favor, and so were the primary care providers. And we did it again the following year and got pretty much the same thing. So no significant differences here, but it just shows that everybody who's been involved in this has really bought in and been very positive about the way it's been working, so they highly recommend it. This is a bit of a strange question, but we were trying to find a way to ask about the issue that Chris brought up earlier about people peeing in the plants and all that. We're trying to see, do you perceive there being an appropriate balance between behavioral health and non-behavioral health patients in the clinic? And the behavioral health respondents, by and large, agreed, although it was not really strong agreement. And the primary care providers agreed a little bit more strongly. So across all of these questions, you see the same sort of pattern where the primary care providers were actually fairly well bought into this, and the behavioral health providers, they agreed, but you all need a little self-esteem boost, perhaps. All right, other measures of integration. Aside from surveying the staff, and by the way, we have newer data than that. I saw Elise Tratters on. She is taking the lead on looking at the newer data and analyzing that. We hope to have that out shortly. Other measures of integration, we also went in for site visits. We did what's called the dual diagnosis capability in healthcare settings scale, and this was created by Dartmouth, and basically involves a site visit that usually is a few hours. You go through the site, you talk to people who are there, who are working there, patients if you can, go through records to see how things are being recorded. And you get scores on each one of these various domains. So this is just overall scores averaged across all of the different sites that we visited in 2011. You could see this way that there were differences depending on the different domains, and I don't think we have time to go into each one of these, but the interesting thing is in 2012, you can see there were really some fairly significant differences from one year to the next. So, for example, in the training domain, it was 3.3. Kern County held a number of training sessions in between, so that helped raise it up from a 3.3 to a 4.3 because a lot of the staff went to those. Staffing, they tended to hire a bunch of people, and you can go on and on. The screenings, the interventions, the treatments, they got more consistent, I think, across the years. And we also did 2013, and I'm sorry I did not have a chance to add that to the slide, but we saw generally the same pattern where it continued to at least stay the same or go up in all domains. So that was very positive. And that's something that I recommend, although it is a little bit time-consuming, admittedly. It is a little trouble to do this, but if you can afford to do it, and you can ask Chris about this later, you get back a report that has specific recommendations about how the scores can be increased, and our feedback on these reports has been fairly good. Another thing is screening data. So all the organizations have been doing all of these in the GAD-7, PHQ-9, and Audit C+. So you can track that across time, either through electronic health records, if you're lucky enough to have one that takes all this information, or some of the organizations have been giving it to us. They hope to do that in the future, but we've been going to get it in Access databases or Excel, and that's fine too. It's important, I think, to track this kind of information once you start doing screening, whether it's fully integrated and it's perfect with your EHR. Just start recording it somewhere is I think, the important thing. So here you see an example of screenings per month for one of the organizations, and you can kind of see from this what's going on and why was it more in November than other months, and why is it really going down now? And so you can based on this data, you can go back and review policies. Okay, well, the person was out this month, and that's why it went down. What can we do about that? And another thing that you can look at is the scores. So here you see PHQ-9 scores among patients that had an initial positive screen, and then they had another follow-up screen later. So hopefully, if the person is getting a positive screen and they're able to have a behavioral health person talk to them, then what you would want to see is later on when they come in again and they get another screen, their score would go down, right? So that is what we see. It went down from 15.9 to 12 in this organization. The average time between the two screenings was 73 days. The only caveat of this is that not everybody had a second screen. In fact, only about a third of folks in this organization had a second screen, and this was the one that was doing the best of the three organizations. So part of that is because it was relatively new. It takes a while. People don't always come back. They might come back 2 years later, so they're not going to get another screen quickly. But you hope that they would get involved and engaged in behavioral health treatment if they're depressed. So this is something that we're working on. I think this is certainly better data than if it had gone the other way. If the scores had gone up the second time, then obviously that would have been alarming. So this is moving in the right direction. But data-wise, we hope to get better data as time goes on. And we're doing the same kind of thing with GAD-7 and Audit C+. So planned future and ongoing work, we plan to continue to work with these two organizations in Kern County to do, we've done, as I mentioned, more follow-up surveys and DD chicks visits. We need to continue to work on the data quality for the screening and service data that I didn't show here, but we've gotten some of that from Clinica Sierra Vista saying that we treated people this many times, and that's very useful. We can look at that in conjunction with outcomes. We've performed a few patient perception focus groups. That was very interesting. They tend to be very positive about their mental health, their experiences with behavioral health. So that was good. There were a couple of small concerns, but those were things that were easily addressable, so I think that was productive. Right now, we're trying to do patient outcome interviews. This has gotten off to a slow start, but we're trying to get people who screen positive on the Audit C+, so they have a drug or alcohol problem, and then just following up with them 30 days later. So doing an initial baseline interview and then 30 days later to see, well, what's their drug and alcohol use like? Were they able to get services? If they did, then what did they think of them? If they weren't able to get them, then what was it that stood in the way of them seeking those services? And then we plan to continue additional training and technical assistance. So this has been a very positive experience, I think, for us as UCLA. We've learned a lot working with these organizations. The leadership in the county has been great, and the people like Chris and Dr. DeWar from Omni and people from the Kern Medical Center have been really great. So that's my quick overview, and I think we wanted to leave a little bit of time for questions, so I will turn it back over to Christine. Christine? There we go.
Okay, thank you. Yeah, I'll put this up so people can see and see the bios if they didn't get them before. Yeah, we had just really two questions, and I think one of them was answered during one of the presentations, and it was, can you bill for 2 services a day for expert for an FQHC? And I think Chris mentioned earlier that it was 1 billing a day. I was wondering whether that was just in California or if that's a standard rule for billing for Medicare.
Well,
Let me clarify that because that's a great question. In California, there is an expert rate. So you can have your standard medical billing, and then you can add to that a supplemental expert billing. I think it's about $25 per expert. So you can do that second billing you can get the full PPS rate or your full wrap rate, your full site visit rate plus the $25. The other option for doing same-day billing comes from the Medicaid managed care plan. So in Kern, we have contracts with 2 plans. One of the plans will pay us the plan rate for a behavioral health visit done on the same day as a medical visit. We can't get the wrap, and I can try to break this down in a second. But for those of you familiar with the concept, you know the wrap is the additional payment that you get from the state to make your PPS rate whole. So my PPS rate, as one example, is $116 a visit at one particular site. The Medicare Managed Care Plan has an agreement with me to pay $58 for a behavioral health visit. I get the other $58 from the state in the form of a wrap. I can do that. I can get that half of that. I can get that $58 from the plan even if it's on the same day because I don't have a prior authorization requirement and because the plan will pay me that. But I can't get the full PPS rate same day, and the other managed care plan in town, the other Medicaid managed care plan, will not pay me for same day. They require prior authorization. So it varies, and it's something to work out with your Medicaid plan. Expert, though, will always pay you an extra, I want to say, $25.
Okay, thank you. And the other question is, for follow-up PHQ screens, could this be drastically improved if the behavioral health staff could reach out and reassess patients by phone?
Sure. I think what happened in the, I think that the next set of data that Dr. Urada goes through, he'll see a much better response rate. A lot of it was simply that we were working on referrals by any means necessary, and many of the time the means was not a PHQ-9 and was not the screening. Initially, the most prominent reason why we got referrals was from the interview by the doctor, and maybe there wasn't a good follow-up on getting that data done. Again, 1 in 9 people come back, so your PHQ-9 follow-up is going to be limited to pretty much that 1 in 9. But the 1 in 9 that come back 6 to 10 times each, so we should be able to get a better PHQ-9 just by practicing more. The phone would be fine. Lily, sorry.
I just wanted to add another wrinkle to this. One of the things that I found very curious as the County Alcohol and Drug Program Administrator who oversees the specialty substance use disorder publicly funded system of care is that we had substantial positive screens for substance use disorders in primary care. And those patients are not willing to go to the other clinic. Even if the other clinic is a quarter mile across the street, down the road, to that clinic, they would rather deal with their substance use disorders within the confines of primary care. I think some of that reflects the fact that here, certainly in California and certainly in my county, that a majority of our clients in substance use disorder treatment are criminal justice involved. What you have in primary care may be an individual who is a long-time addict, long time alcoholic, someone dealing with pain medication, addicted to opiates, but is not criminal justice involved and therefore doesn't want to go down the street to that other clinic. So I think it's really critical for those of you that are representing the substance use disorder field, think about how important your role becomes in primary care, especially with substance use disorders now being part of essential services for the ACA.
Hear, hear.
Thank you. Another question came in. What types of interventions do the LCSWs primarily use for patients testing positive on screens?
It's typically motivational interviewing, including the expert, and then solution-focused brief therapy. Group therapy is also quite beneficial, but it's difficult to do on site in our older settings because they don't have a big space for the group. I should point out we've built 2 new community health centers since then, and we have built them by a different design. We have built them so that all the providers huddle in the middle. If you picture a tire, picture a wheel, spokes of a wheel, all the providers are in the center, and then the patients are around the outside ring of the wheel based on what they're there for. And we've built in large rooms to accommodate large family therapy sessions and to accommodate groups, including substance use groups. But we primarily utilize solution-focused brief therapy, some paradoxical therapies, strategic therapies with folks with addiction, and motivational interviewing and expert.
Okay. I don't see any other questions at this point. So we can close this. Oh, you know what? There were 2 poll questions that were sent in that weren't used. So I'll go ahead and do those 2 before we close this part of the webinar. Just a moment here. Okay, sorry. Okay. This is one of the 2 other poll questions. How do you access your current efforts at integrated behavioral health? I'm sorry, how would you access your current efforts at integrated behavioral health? I can't even read the question. You think about integration. Are you planning for integration? Have you begun integration? Are you integrated but looking for ways to improve it? Or are you completely integrated? We will launch that.
How would you expect?
And while people are answering, I will mention that this webinar is being recorded, and the webinar plus the PowerPoints will be available by tomorrow morning at our webinar library, and I'll send everybody the links to that. It will be in the expert section. So you can view this in any of our other recorded webinars at any time you want through that link. Also, tomorrow morning you'll get an email from me that will have a free certificate of attendance, a link to ordering either Pennsylvania or NADAC certification certificate, and like I said, it will include the link to the webinar library as well. Okay, so I am going to close this poll and we will review these answers. 1% of, or 13% of the people attending today are thinking about integration. 38% are planning for it. 25 have already begun. And 25 are integrated but looking for ways to improve. And nobody is in the completely integrated section. So, and then for the last poll that was asked, how are your services funded? Are you a fee-for-service PPS rate? Are you capitated, grant-funded, especially mental health, contract, or other? Okay, thank you. I will close this now and share these results. In the group today, 57% are grant funded and 43 are other. So
I can
that,
just I can jump in, Christine. That's the big challenge. How do you afford to do integration between during this interim period where most of us are fee-for-service funded until we get to a point where you actually have the reality of that promise of alternative payment methods, accountable care organizations, medical homes and health homes. And so hopefully for that group that was planning or thinking about, you can see this model is at least one way to pay for the service just on that widget rate that we're all stuck in. We are all rooting for and hoping for the alternative payment methods so we can provide better care. Sorry to butt in, Christine, but
Oh, no, that's why you're unmuted here. We want your input on these. So we have asked all of the poll questions, and I think that we have answered any questions that came in from the attendees. So I think that really completes this webinar session now. I'm going to take a couple minutes and go over our National Expert ATTC website for anybody that would like a brief overview of that and see some of the resources we have available there. So at this time, I would like to thank the presenters, and I'll be sending you the results of our evaluations as soon as they're available. So thank you, presenters, and I will mute you now so you can get off if you'd like. Okay. Okay, now for the rest of you, I'm going to switch over to our National Expert ATTC site, and I will send you a link to this as well tomorrow. We are part of the National ATTC Network, which is Addiction Technology Transfer Center, and there are 10 regional locations across the country and then 4 national focus areas, and we are one of those national focus areas. If you're not familiar with the ATTC network or where your regional centers are, you can just go to Find Regional Centers on the website and click on your region. I'll just pick Southeast ATTC. You can see it here in dark blue, and Southeast ATTC covers those particular states. So I'll click on there. This goes directly to their website. It has Contact Us. It shows you all the programs that they're working on now. And there's a lot of information for all these different sites. You can go over the whole country checking to see what's available from all these different networks. It's really wonderful to see what everybody's doing. This is Oregon. They do an awful lot of expert work too, and they have a new curriculum out. So this is one other one to look for. And then there's also the national location too. So I will now, and then this is for the national centers like we are. So there's a center on the National Frontier and Rural Issues, ATTC, that's a national topic area. The National Hispanic and Latino, ATTC. National American Indian and Native American, ATTC. And then back to us, we're the National Expert ATTC. If you'd like to see what the regulations are in your state for expert, you can go to our brand new map here. And this goes to the IRETA website where we're housed. You can click again on any state and see what the regulations are for that state. This has all been entered and continues to be updated as things change. So this happens to be California, says when the year was effective, the codes, the reimbursement levels, and any additional information. So you can do that for any state too to see what's available to you instead of looking through a lot of different government websites, which isn't easy to do. Okay, so I will go back to us now. If you're looking for a trainer, say you want somebody to train experts in your area, We have a site where people have submitted their names, or again, you can go to different regions. Here's Texas. These are the names of the trainers in the area who have been approved by the ATTC there. You can click on any person's name then and see exactly how to contact them and some of their background information. So that's a really good place to look for trainers. You can go to our training section to see what face-to-face and webinar trainings we have available. We also have and are loading in more now of the different expert programs going on across the country and the resources that they have there. We also started this new digital tools section where we are starting to put in some very short overviews of different programs we have. And now we have the partnership information and distance learning, and are actually putting together more online expert curriculum, and we'll have that available. And then our e-newsletters, we have a I read a in general for expert lab, and you can get this on the newsletter, so it's not going to clog up your box. And webinar, and also and I board expert so this is a great course. I hope you love it, along with all the other sections. Now, again, tomorrow morning you'll be getting an email from me to various topics within this week. And also about an hour, and also tomorrow morning getting to the evaluation. Very, very important. How you all looked at our so give us. I think at this time I will close this off with to take all the other information. So thank you very much for joining us. Hope you work.